I'll leave all my inappropriate comments about this one.
Oh, I'm so glad you weren't here last week, Matt.
Why? Is this part two?
This is part two.
I missed
the first
So
one
we
too.
did normal sleep, and we'll be alluding a little bit back to the first presentation, but you guys missed out. I'm sorry.
Was it good?
Yeah, I don't know. Was it good, you guys? I hope it was good.
Yeah,
I hope
sorry.
it was useful. So hi, everybody. I'm Nancy Martin. We had the chance to cover normal sleep patterns and to talk about some things that individually might be occurring for people to not be getting a great night of sleep. So this week we're going to be concentrating on sleep disorders. Some of these are really, really fascinating. I concentrate on the the heavy hitting, most frequent sleep disorders, but I include a couple of the odd ones too, just because they are so fascinating. I have to say this is an entire fellowship, sleep medicine, so I'm going to be condensing a lot of material. We're not really going into a ton of treatment, just going over the types of sleep disorders and what that might look like on some of the EEGs or hypnograms that we talked about last week. So let's just pop right into it. So we're going to discuss the classification of sleep disorders. We're going to review normal sleep structure, which is something we talked about last week, so it'll be brief. And then we're going to define some specific sleep disorders this week. Okay, so when it comes to classification of sleep disorders, the most recent grouping or organization of how these are classified decided to do this really by primary complaint. In total, there's 85 identified sleep disorders, and there's about 8. There are 8 major categories. We're going to cover these 6. So the insomnias, hypersomnias, parasomnias, the circadian rhythm disorders, and then sleep-related breathing and movement disorders. The 7th category is kind of the trash bin category. It's the other sleep disorders, or the as Niels was saying, the not otherwise specified sort of grouping, so it's not that interesting. And then the 8th category is more isolated symptoms or normal variants or unresolved issues. So these are the 6 that we're going to concentrate on today. Okay, so again, it's by primary complaint. Somnia meaning sleep, so we can think about the first 3 grouping about why they're named the way they are. So insomnia, not being able to sleep; hypersomnia, sleeping too much; and then parasomnia, things happening around sleep. We covered circadian rhythm, normal circadian rhythm last week, and so when we talk about this disorder, it'll be important for you to build on that knowledge. And then we always have something wrong with the way that we breathe or the way that we move in general with the sleep-related disorders. So let's talk about these specifically. So the issue by primary complaint with insomnia is difficulty with sleep initiation, starting sleep, maintenance, staying asleep, or final awakenings that's earlier than you would like and leads to dissatisfaction with sleep quality. Okay. Hypersomnias, basically the primary complaint is daytime sleepiness. There could be a whole list of reasons for that, but that's the primary complaint with the hypersomnias. The parasomnias is undesirable physical or experiential events that accompany sleep. And I knew you would have that reaction, Matt. So we're going to go into I'm going to define what this is. But this is going to be like things like sleepwalking, sleep talking. And that's going to depend on what type of sleep somebody's in, whether they're in rapid eye movement sleep or non-rapid eye movement sleep. Okay, so the circadian rhythm disorders, it's this recurrent, persistent misalignment between the actual or desired sleep pattern. The breathing disorders, so it's disordered respirations during sleep. And we'll talk about the 2 subtypes of that. Mm-hmm. And then the movement disorders, so simple stereotype movements that can disturb sleep. So that's kind of the overview of where we're going. Just as a reminder from last week, this is a normal sleep pattern, okay, or sleep stages. Whoops. So what we see here is this awake, relaxed state, and then the various stages of sleep that we go into, with rapid eye movement being the deepest, most restful, and where we're dreaming. Stage 1 and 2 being, lighter sleep, and then stage 3 and 4 being the deeper sleep, okay? This is what the equivalent EEG pattern looks like that we covered last week too. So that's just a little bit of a review. Again, a review from last week that sleep latency is the time to when you close your eyes to when you actually fall asleep. And that's characterized by alpha waves. Stage 1 and 2 are the lighter sleep, and they have very characteristic things in each of those as well. And then stage 3 and 4 by delta waves, that's when the body's repairing itself. And then we've got stage 5 with rapid eye movements. And remember that with rapid eye movement sleep, in general, when you have a normal rapid eye movement occurring, the body's motionless. You are paralyzed. Okay, so that's when you're doing a lot of the vivid dreaming. Okay, so let's start with our category of insomnias. So again, this is the symptom with difficulty with sleep initiation, maintenance, and final awakenings that leads to that dissatisfaction with sleep quality. The symptoms can occur despite adequate time or opportunity for sleep. So say you've given yourself 8 hours, it's not for lack of having 8 hours. If there's something just wrong with your ability to start sleeping, keep sleeping, or wake up when you'd like. And that results in some form of daytime impairment or sleepiness. Okay. This can include complaints that are characterized by the perception that there's poor quality or there's non-restorative sleep, even when the amount and quality is adequate. And it's either, it's misspelling, that can be either primary or secondary in nature. Okay, so this is the crouching sheep, not being able to fall asleep, initiation issue. So there's intrinsic and extrinsic factors that are involved in the etiology. And what I mean by that is it can either be something that's going on that's wrong with the physiology of the body, or some of those things that we talked about last week when it comes to the to regular sleep hygiene. So is it an external factor like the temperature of the room? Is it the TV being on? Those are some of the extrinsic factors that we talk about. There are multiple types of primary insomnia. The one that's most common is something called psychophysiologic insomnia. And like I said, it's most common, it's usually present for a month for it to be an issue. And it's characterized by this heightened level of arousal with learned sleep preventing associations. So some things can go wrong and then people develop bad habits on top of that. And this is where, I think Dr. Hatfield last week was talking about cognitive behavioral therapy for insomnia. This is the group that we aim that therapy towards, okay, because there's something to correct. We have something called paradoxical insomnia. So it's that complaint of severe insomnia despite there's normal sleep pattern and there's really no evidence that the sleep pattern is disturbed when you have somebody in the sleep study. Okay. There's something called adjustment sleep disorder. And this I would imagine in your line of field could happen for you, but this is basically insomnia associated with a specific stressor. So that stressor can be psychological, it could be physiologic, it could be environmental, it could be physical. So this is really, not to over pathologize sleep, but these are when you've lost a loved one or you've had a really, horrific thing happen during the day and you don't sleep that well that night. If this persists, it could qualify as adjustment sleep disorder. And then inadequate sleep hygiene. So again, we really talked about this last week, but this is, the behaviors associated with those daily activities that are really inconsistent with a good sleep pattern or quality. So it's like irregular sleep onset or wake times, the stimulating activities before bed, or ingesting substances like alcohol, caffeine, or nicotine. Go ahead, Matt.
I don't know if this was covered last time, but this is Matt Tan with APD. So in law enforcement, there's a lot of shift work. And what if you are on graveyard and you're having trouble sleeping because of during the day?
Great
How would
question.
that fall?
It doesn't. It falls into the circadian rhythm pattern, and we'll talk about that a little bit more. But yeah, great question. Because you would think like that, and that's really not sleep hygiene. That's not anything you can change necessarily. If that's the shift that you're working, it's not because you have bad sleep hygiene, it just is the shift you're working. And that then becomes a circadian rhythm issue that you're dealing with. So different class, but yeah, excellent question. Okay, and then secondary insomnia. We as psychiatrists talk about insomnia as a symptom of depression all of the time. It's one symptom that has to be present in general for there to be some disturbance in someone's sleep during depression. Very, very common as well. And so that's not a primary insomnia issue. It can be. Somebody can have depression and a primary insomnia issue, but typically that's secondary insomnia. And so this is, insomnia related to a medical or psychiatric illness or a substance use issue as well. And we covered methamphetamine, cocaine, both of those being dopamine-releasing substances, can really impair that deep REM sleep that people, get that restful, dreamlike state, and they can have REM rebound sleep issues because of it. And so that would be secondary insomnia. That makes sense? Again, we could spend a month talking about each one of these categories. So I just want to give you an overview of what all these are like. So let's diverge a little bit into something about how much sleep is needed. We talked a little bit about this last week, But really, it's different for every person. For most adults, it's anywhere from 6 to 8 hours. But for you, it should be the sufficient amount of sleep that's required to feel alert, refreshed, and avoid falling asleep unintendedly during waking hours, okay? Naps are fine. Naps are great. If you plan on taking a nap or plan on falling asleep, it doesn't mean that you're not receiving a sufficient amount of sleep. But if you're falling asleep at the wheel, if you're falling asleep during a meeting, some people would even say if you're falling asleep during my boring lecture, you're probably not getting enough sleep, okay? So let's talk about a little bit about sleep deprivation and what we know in the research. So we do know that there's, of course, still decreased alertness, that your response time is slowed. You have increased appetite, increased stress hormones, and then cognitive impairment or problems with your thinking ability. And those have long-term effects for people. So we notice people who, who consistently don't get enough sleep have higher blood pressure, possibly leading to hypertension. They have heart failure, stroke, and obesity. And even just reducing your sleep 90 minutes for one night can reduce your daytime alertness by up to 32%. So it's a night-to-night issue. Sleep debt is a real thing, but even from one night, you can cause some problems. What do we know about, specifically these things? So one, long-term mood disorders, chronic sleep debt can actually lead to or worsen depression and anxiety. I don't like to think about sleep deprivation as being the causative issue behind depression and anxiety, but certainly I see disordered sleep often with those two illnesses. It has an impact on your body's ability to defend itself in terms of your immune system, so it leads to more sickness. It can make it easier for you to get sick. Okay, and then difficulty with recovering as well. 3, again, the diabetes, the sugar diabetes, people who sleep less than 5 hours a night have an increased risk of developing diabetes. Infertility can have some problems with secretion of reproductive hormones, so people with chronic sleep deprivation have trouble conceiving. And then weight gain, as I alluded to earlier, so people who sleep less than 7 hours a day are 30% more likely to be obese, not just overweight, but obese. And then kind of tying into this infertility picture, 6 is low libido. So men and women who don't get quality sleep have decreased interest in sex and may even have decreased ability to obtain the necessary means to engage in sexual activity as well.
What does that mean?
Maintaining and obtaining an erection. Or orgasm. Yeah.
Did you just say that?
I sure did. Yeah.
Oh, we're having a circadian rhythm method.
No. That is completely separate. We will not be covering that today, Matt. But thank you. And then 7 is heart disease. So long-term sleep deprivation can be, like I said, associated with increased heart rate, blood pressure, and then a higher level of chemicals that are linked to inflammation. Okay. So this bottom chart here says how much should we be getting? How much sleep should we be getting? So newborns, as we were talking about last week, really do sleep a tremendous amount. Might not be continuous, but around 16 to 18 hours a day. Preschool children around 11 to 12, dropping naps by age 6, school age 10. And then teens oftentimes require more than they did. So I think that's a low estimate on this graph. And then adults anywhere from 6 to 8. Okay. At least 100,000 crashes and 71,000 injuries, along with 1,500 deaths each year in our country, are related to people falling asleep while driving. In most residency programs, if you have worked longer than a 12-hour shift and you need to drive home, they'll have a driving service to prevent this from happening, or a cab service. Yep.
Did they do that here?
Mm-hmm. Yeah.
Did they do that when you were in residency?
Oh, they did. Yeah. I never utilized it.
Kids today.
I know, but I like to take this a lot when I was working night shifts, but yeah. And this is why, because it's really dangerous.
I think for officers,
That's a good idea.
Especially we're on 10-hour shifts, but there's some agencies that are 12 hours.
Mm-hmm.
And you do that like in graveyard, when I worked graveyard, there's times I didn't remember how I got home.
Right.
So all of a sudden it was at home in my car.
Right. I mean, it's a learned behavior, right? Driving, just like riding a bike. So if people who teach and practice mindfulness, one of the aspects of it is driving, that we spend a lot of time in the car, and most of the time our mind is elsewhere. If you imagine being sleep deprived and then also doing distracted driving, it's not hard to imagine that there's that many motor vehicle accidents related to this. Okay. So back on track then with
Wait, so if you're working as a doctor, you're seeing patients right up till you leave, but then the hospital says you're not good enough to drive home?
Well, they offer it to you. Yeah, no, I agree if they offer it to you, but.
What time is shift change? So we don't have to go during that.
You don't want to get sick in the month of July, y'all.
Yeah,
We're about to be sick. We're about to be coming on to our newest residency classes starting in July, and there is actual data that there are poorer outcomes in July. So please don't get sick in July.
Matt, write that down.
Well, he was already sick.
Eat
So,
better.
yeah. Okay, so that's the insomnias. We talked a little bit about why not sleeping is bad. Let's talk about hypersomnias, okay? So this is that primary complaint of daytime sleepiness that's not caused by disturbance in nocturnal sleep or misaligned circadian rhythms. Okay, this is the inability to stay alert and awake during major waking episodes of the day. This isn't, you zoning out post lunch because you're sleepy or it's 12 p.m. and you're tired. This is during major waking episodes like 8 a.m. or 10 a.m. That result in unintended lapses into sleep. Okay, and so this is one you've probably heard a lot about, is narcolepsy with or without cataplexy, and we're going to spend some time talking about that. But then there's also menstrual-related hypersomnia. So depending on when a female is in her menstrual cycle, there can be issues with feeling sleepy throughout the day, and that's mostly hormonally related. And then hypersomnia is related to a medical condition or drug use, and some of those make sense, and we'll talk about them too. Okay. So narcolepsy, everybody always finds this really, really interesting. It's a sleep disorder that's characterized by excessive sleepiness, sleep paralysis, hallucinations, and then some episodes of cataplexy. And what I mean by that is a partial or total loss of muscle control. So that can lead to slack jaw, weaknesses of arms or legs, and that's often triggered by a strong emotion like laughter, like sadness. It's very bizarre. It's really bizarre. In narcolepsy, there's a cluster of cells that produce hypocretin that we talked about last week, or that's also known as orexin, and that can be damaged or completely destroyed. So without that chemical, our brain really doesn't have our alerting system that wakes us up. And I'll review what we talked about last week, where in the brain that's produced. So it occurs equally in females and males, and it's more common than I would have thought. It's 1 in 2,000 people. So these people feel very sleepy during the day, and they may involuntarily fall asleep during normal activities. And you can imagine how dangerous that is, falling asleep while you're doing the dishes and falling and hitting your head, falling asleep while driving, falling asleep, you name it, and what it is that we do and how it is that we keep our body safe throughout the day. And these are unexpected lapses into sleep. So narcolepsy can happen with or without the cataplexy. Okay. So if you're interested, there are plenty of videos about narcolepsy on YouTube. Some are good quality, some are not. There's a BBC documentary about a man who lives with narcolepsy and has pretty much broken every single bone in his body. He wears a helmet because of it. So you can imagine how impairing this is socially for people who have this illness. So the way that it's diagnosed is there's a time frame, as is most things. So it's at least 3 months with excessive daytime somnolence. And then you confirm it with the somnogram. And it's a minimum of 6 hours that somebody's watched overnight with something called a multiple sleep latency test. And that just basically says, how long is it until you fall asleep from when you're trying to fall asleep? And so there's some criteria around that as well. So just as a reminder, this is that, we covered this last week about the different signals in the brain that help us to wake up. So we have this orange wake signal branch, and the orexins or hypocretin are produced in the hypothalamus, right? And that helps wake us up. So right here for the hypothalamus. So people with narcolepsy don't have that cluster of cells, or some cells are missing, and so they don't have that chemical helping them. Okay, so that's the hypersomnias. Now let's talk a little bit about the parasomnias, the things happening around sleep. These are characterized by, again, undesirable physical or experiential events that can accompany sleep. They consist of abnormal sleep-related movements, behaviors, emotions, perceptions, dreaming, or autonomic nervous system functioning. This will make more sense in a minute. And they can also be considered disorders of arousal or sleep stage transition. So going from sleep, stage 1 to 2 to 3 to 4, or some manifestations of central nervous system activation or changes with skeletal muscle activity within the autonomic nervous system. Okay. They're classified according to when they occur, whether it's during rapid eye movement sleep versus non-rapid eye movement sleep, and that's why I was trying to make that distinction early on last week about these. These are our sleepwalkers in general, okay? So again, if we break it down according to non-REM versus REM sleep, we'll start with the non-rapid eye movements. This is when your body is not paralyzed. So this makes sense, right? This is when sleepwalking happen, sleep terrors or night terrors happen, and then something called confusional arousals, which I would bet some people, on today or even here in the room have experienced in the past. Okay, so this is, again, not to over pathologize things, but to give it a name of what happens. So let's start with sleepwalking. This condition affects about 4% of adults. It's pretty common in kids. It's 15 to 20% of children, and they typically outgrow it. But this disorder is actually not just limited to walking. Other behaviors such as sleep eating, sleep sex, sleep driving, or even sleep texting are becoming increasingly more common. Children, when they have it, seem relatively calm, actually to the point where like a casual observer would think that they're just walking around and doing whatever they're doing. And then sometimes what happens is that a child gets up and urinates in a place that's not the toilet, and that's how the parent is made aware of what's happening. Sometimes it's parents, just the child coming to the bedside and saying something and seeming maybe not all there to the parent. And then less commonly, they can become agitated or run around. And that's when the behavior starts to look more like a night terror or a sleep terror. So sleep terrors are more fear, terror, disoriented, and then you see a lot of autonomic responses in the body, like sweating, rapid heartbeat, screaming and thrashing, and it's pretty frightening when you see a child have a night terror and they have no recollection of having that episode, but it's, for the people who are experiencing, it's really scary. And just like most of the parasomnias, children tend to have those more than adults, thankfully, and they tend to outgrow them as well. And then finally, this confusional arousal it's when people arouse from sleep, they're confused, disoriented, maybe experience memory or speech problems, and the timing, obviously right around sleep, and it's short-lived. So that can be, if you're awoken by a spouse or in the middle of deep sleep, you might say something weird in the sleep and not have any recollection of it. Okay. So those are the non-rapid eye movement sleep-related parasomnias. Rapid eye movement sleep parasomnias are a little bit different. And again, this is happening during a period of time when the body is paralyzed. So we have rapid eye movement sleep behavior disorder. So people can experience really, really vivid dreams, even more than you might imagine during just regular rapid eye movement. And they might try to mimic that behavior during their dreams. So I know that's confusing, right? Because the body's paralyzed, but sometimes with an REM-related parasomnia, the body is not paralyzed. And so you can see people acting out these extreme dream-like states. So there's a really good video on YouTube, too, of a Japanese man acting out a samurai sword fight. And it's pretty intense, and it's obviously very dangerous for a sleeping partner if somebody is going to be assaulting you and not have any recollection of it. Okay. Hallucinations or nightmare disorders. So if people can experience more frequent, more severe nightmares during this stage. Sleep enuresis or trouble, going to the bathroom bedwetting. And again, that's more common in children, and they outgrow it. And then something called exploding head syndrome, which sounds like I'm making this up, and I'm not. But people who have this, and I can't imagine how scary this is, feel that they have like an exploding bed in or near their head when they try to fall asleep. And it's oftentimes, if it happens for people, it's related to insomnia, jet lag, some emotional tension or stress. And so it can occur for people.
There's a question.
Sure.
Does the night terrors partially explain for possessions in early colonial cultures, witches into mounting possessions?
Oh, that's a really terrific question. Is this Detective Chacon?
Yeah, he's an officer.
Okay, officer. That's a really great question. I don't know if anybody's ever looked into that. it would be really, there's so much about medicine and what we understand now to be, like seizure related behavior. So after somebody has a seizure, they can do some really strange stuff. And we might not have recognized that before we knew the seizures were happening. So I don't know. That's possible. I know, defense attorneys like to use these when there's a murder that happens or a murder trial, that this can be something that they build a defense around, or they were having a night terror, or they were having a, REM sleep behavioral disorder. That's why they stabbed their wife. But this is all confirmed with studies in sleep medicine. So.
What about the saying about you shouldn't wake someone that's sleepwalking? Is that true?
I don't know. I think that sleepwalking can be really, really dangerous if you consider, like, if you have a sleepwalking child and you're going camping and you're near a cliff, there are obviously some really dangerous behaviors that can come along with sleepwalking. And so, yeah, I think if it's dangerous, you absolutely should. But I think experts would talk about guiding the person back to the bed, making sure that they're not near stairs, that sort of thing. Does that answer your question? Okay. Okay, so those are the parasomnias, or things happening about sleep. Let's talk a little bit about the circadian rhythm disorder. So, of course, they share this common underlying chronophysiologic, so chrono meaning time, physiologic meaning how our body works, basis. And it's this recurrent or persistent misalignment between actual and then desired sleep pattern. So, keep saying this, I know, but I don't want to over pathologize things for people, but there is, for teenagers, for parents of teenagers online or in the room, there's this delayed sleep phase issue that most teenagers go through. They don't want to go to bed at 8 p.m. like they did when they were little. So they might have a problem with their sleep, their circadian rhythm going along with what the rest of the family is doing. So that's called delayed sleep phase, and that's more common in adolescence. And then advanced sleep phase is the opposite, so where people are going to bed earlier than they really like to, and that happens a lot with older people. I always used to laugh that my grandma couldn't make it, couldn't stay up for the 8 o'clock news, but she just really couldn't because she had this advanced sleep phase circadian rhythm issue.
This is Matt Tinney with APD. I have a question for Dr. Rosenbaum. What time do you go to bed?
8:15.
Okay, thank you.
What time do you get up?
No, I don't go to bed.
Okay, so those, again, not to over pathologize, but this is where those groups of people would fit into, so delayed or advanced type sleep phase. A regular sleep phase would mean that they just have no pattern, okay? And then, Matt, what you were alluding to early, shift wake sleep type, is that somebody who's having to work 3 nights on, 3 days off, or whatever pattern somebody has, they can have a shift work sleep type circadian rhythm disorder, okay? And then jet lag type, which has always been really fascinating to me, but specifically because it seems to be worse when people are traveling eastward. But if we get on a transatlantic flight and you find yourself extremely sleepy despite the fact that the sun is up and sending all of those signals to your brain that we talked about last week about not producing melatonin, that your body's still in the time zone that you came from. So. This is luckily transient. For some people, it can last, upwards of weeks or a month, or take some time to get back onto a normal circadian rhythm. But that subtype, it would fit into jet lag type.
With these disorders, is there an actual treatment, or is this, what would you do?
Yeah, absolutely. Yeah. So this is when I like to use sedative hypnosis for people. Like say you've got a high-powered business person who's traveling to Europe or Asia multiple times, in a year and doesn't have the ability to recuperate in some other ways, or it has to be working when they get there, that we utilize a lot of the sedative hypnotics. We call them the Z drugs because of the generic names like Zolpidem or Ambien. So that's when you would utilize these medications. I don't like to use those medications long term. For a lot of different reasons. They can, Ambien in particular has a lot of abnormal sleep-related behaviors. So people will go and order a ton of stuff online and not remember it. There's actually a really great page on Pinterest called Stuff I Ordered While I Was Taking Ambien. And it's really funny. But people will do other odd behaviors like eating. They'll prepare an entire meal, eat an entire pie, take a bite out of a frozen pizza, just do some really bizarre things on that medication in particular. So I don't like to use it, but for jet lag, yeah, absolutely. If you're, if it's short course, I think it's fine. So.
What about other stuff like the shift work one?
Mm-hmm. Yeah, so we covered this a little bit last week, that shift work, sleep type is difficult because it's part of a lifestyle, but ensuring proper sleep hygiene is typically the thing that's going to work for somebody who's making a life out of that. For our residents who work 2 weeks in a row, that we sometimes recommend other things, that you can try other sleep aids, one of them not being alcohol, but trying other sleep aids to make that transition. For me, I usually would have like a small dose of Benadryl and a Chick-fil-A chicken biscuit, and that was good. Spicy chicken.
Specialized.
Special, yeah, absolutely. So,
chicken biscuits are always.
But I don't like. Again, I really don't like to use the Z drug, the set of hypnotics for some of these things. If it's short course, it's fine, but they're addicting. People can get themselves into trouble with them. So it's just case by case. I make that decision for people. Okay, so let's talk a little bit about the sleep-related breathing disorders. These are obviously just characterized by problems with breathing, respirations during sleep, and there's two, sort of types. There's central apnea disorders. So this is respiratory effort that's diminished or absent in an intermittent or cyclical pattern, and it can be primary central sleep apnea or secondary sleep apnea. With primary typically being due to some central nervous dysfunction, and then secondary being involved with, long-term substance use, like particularly opioids, and around 2 months of opioids, because that drug in particular works on the mu receptor in the ventral medulla of the brain, and that's a sleep center. So people can have obviously problems with their breathing and breathing related issues when they're taking that substance, and that can lead to death. And then the second type is obstructive sleep apnea. And this is probably, you've heard a ton about, you probably know somebody who has obstructive sleep apnea. Somebody in the room might have an undiagnosed obstructive sleep apnea. But this is characterized by the obstruction in airway that results in increased breathing effort and inadequate ventilation. So this, for the longest time, took me, I just didn't understand what is the difference between central and obstructive sleep apnea. Really, central, you're having cessation of breathing, and there's no associated ventilatory effort. There's no associated, drive to breathe. And I'll show you that in a video in a second, okay? But first, let me show you these polysomnograms. So this is an obstructive. Sorry, this is actually, I don't really have this other page. I don't have it. This is central apnea. Okay, so what you're looking at here is about 30 seconds of somebody sleeping. The 2 denotes, that 2 watermark denotes the stage 2 sleep. So from the top, you're seeing, CPAP flow or airflow, chest wall movement. So we have, again, a band around somebody's chest and measuring how often that's, moving up and down. Same with the abdomen, because then we have accessory muscles in the abdomen that help us to breathe. For anybody who does a lot of aerobic sports, that makes sense when you're getting that six pack, because you're moving your abdomen, all those accessory muscles that help move airway. And then the bottom is the oxygen amount. So what you can see here is that not only the flow of air comes to a static level, but so does the chest and abdominal wall. And we see this movement from 97% oxygenation down to 91 at the center of this. So this is central sleep apnea. Okay, there's no associated ventilatory effort with that. Compare that to this pattern. This is a little bit longer. This is a 45 second, 30 second stage. Again, we're in stage 2 sleep, as you see here. These leads, this is extra leads up here. This is the central forehead, and this is occipital lobe, so it's showing you you're in stage 2 sleep. And here's airflow, chest, and abdominal wall movement along with oxygen. And what you see here is there's this, hiatus, about 10 seconds of airflow that's not happening, but the chest and abdominal wall muscles are still trying to get you to breathe. But you're seeing a decrease again from 97 to about 91, 92 oxygenation, okay? And then after that, after this apneic episode, and this flat line is apnea, this is hypopnea, or a change in the regular level of breathing. Then you see this return of, to normal airflow. But you can imagine what that does to the brain too, when somebody is, when they're their body's trying to wake them up to breathe. So just to give you, some overview of the anatomic structures that we're thinking about during an obstructive sleep apnea picture, we have normal breathing when somebody's recumbent lying down. Typically the tongue, when relaxed, doesn't fall into the airway and prevent you from breathing. You've got the soft palate, this is the hop palate or hard palate, the bony part of the palate, and then the soft palate here. And then the uvula, that like hangy little, like grape-like thing at the back of your throat, that's the uvula. Okay, so this is normal breathing, and your airflow comes in through your nose and can travel down to your lungs. With snoring or partial obstruction of the airway, some part of that, typically the uvula, parts of the soft palate, can impair that and result in that sound, that snoring sound for people. You're still getting some air going through, but it's making a sound because of it. So this can happen for people who have larger tonsils too. We stage tonsil size according to a certain severity, and so it can happen with somebody with large tonsils, large neck, obese persons. But general, there's some anatomic structure that's happening causing that. And then with obstructive sleep apnea, you see this complete blockage, that there's no air coming through the airway. Okay. So the treatment for it is something called CPAP, or continuous positive pressure, that goes through the nose and keeps all of those structures kind of open and letting airway come through into the lungs. Okay. Not the sexiest thing, but they're life-saving, okay? Because obstructive sleep apnea really has just as many, if not more, health complications for somebody as regular, insomnia in general. So we see, again, poor sleep with mood disturbance, daytime sleepiness. The loud snoring can cause relationship discord to the point where people sleep in separate beds. And then morning headaches because of oxygen deprivation. We see type 2, all the metabolic issues, type 2 diabetes, obesity, sexual dysfunction, problems going to the bathroom at night. And then all of the sudden, all of those health consequences have sequela in terms of medical illness and then medical costs as well. So yeah, not a good thing. We use this scale called the Epworth Sleepiness Scale, and it might be, interesting for you all later to Google this. This is free, this PDF. To score yourself on, what it would be for you. Basically what this does is, it scores how likely are you to doze off or fall asleep in these common situations, in contrast to you just feeling tired. And it gives us a good baseline level for people. But we catch a lot of people who have obstructive sleep apnea with this. In fact, as a medical student, I diagnosed a relative with this, and his life was changed after getting the CPAP. It's really, really cool. So look at that later. Okay. So right now, I want to show you what an obstructive sleep apnea picture like.
This will be interesting.
Can you hear me?
We're supposed to see something?
Can you not see it?
Are you guys able to see the video? No?
No.
No.
It sounds pretty nasty.
Is that on us? Is that with a CPAP or
No,
just?
this is without.
There we go.
Jackie, we can see you, so you let me know if you can hear this guy. Okay.
So look, he's trying to breathe. He's not breathing though.
His heart stops for 10 seconds.
So right, you still see some movement from the, the chest and abdomen. And there, that was a micro arousal. So you saw his eyes open a little bit, but his brain had to wake him up in order to get him to breathe. Okay, so that's a pretty extreme example of obstructive sleep apnea. You notice his body habitus, you notice the size of his neck, you notice his position of sleeping too. So there's a lot about this gentleman that probably precludes him to having this issue medically. But for him, none of his sleep is restful. So let me show you this from a polysomnogram. I know this is a lot of what you're looking at. Can you all hear me now? Okay, cool. So what you're looking at is an entire night of a sleep study, okay? So at the top, we have what's called the diagnostic part where we look, hey, what's going on? What's wrong with this person's sleep pattern? And then the therapeutic part is when we're applying a CPAP. So this is, I'm just going to go ahead and tell you already, this is obstructive sleep apnea. What you're seeing here is the different sleep stages, okay? And so they're mostly, this person in the diagnostic portion is really only in stage 1 and 2. And you see their heart rate fluctuating, so that's not a good thing, right? Sometimes going upwards of 110. And look at these oxygen saturations. This person is desaturating all the way down to the 70s during their obstructive episodes. So each of these lines is a different time marking of an obstructive apnea, so where they stop breathing. And each of these pink lines is a hypopnea, so not getting that full breath. And then here, this is what's most profound to me. This is the number of arousals. They're too numerous to even count. This is hundreds and hundreds of times their brain is waking up, right? And then here's recorded snoring. So this red line then, changes when it is that the diagnostic portion of the sleep study is over. So they only do about 2 hours. And then the rest of the night, they do titration of the CPAP machine. So this is when it's first applied. You still see there's a lot of arousals, a lot of hypopneas, maybe not as many obstructive apneas, but still some hypopneas. So as the pressure gets titrated to a normal amount, as the person gets used to the way that the mask feels, it goes down to nothing. There's nothing here. And now you can see that they're in restful or, rapid eye movement sleep for a prolonged period of time, and stage 3 and 4 sleep as well. So this is so I completely dork out when I look at these, because I think it's just so profound to see somebody's brain waking up that many times, and then to look at them getting adequate amount of sleep after they've had the CPAP machine appropriately applied and then titrated as well. Any questions about that? Yeah. Okay. That's pretty cool.
This is another dramatic example. This is not.
No. This can be typical. This can be typical of obstructive sleep apnea or central sleep apnea, where the brain is waking up. So of course these people.
The effectiveness of the treatment as well.
So central sleep apnea is treated differently because really it's not like the.
No, but this is obstructive.
Obstructive.
The success of.
Yes. And so there's different masks.
So many
they're not
on CPAP,
all.
and they don't seem like they're sleeping great.
Well, so they're really difficult to wear. One, they're not sexy. No one wants to pop on their CPAP machine and get
Makes a lot of noise.
Right? And so they're a lot quieter now. There's a lot of
is that what you're saying?
Well, maybe from when you first heard them turned on, they're really quiet now. And there's different masks. So there's the one that goes over, the one that I showed you went over the entire nose and mouth, but there's some that just are on the nose. And so I encourage patients who say it's really uncomfortable, I don't want to wear it. They don't have a proper mask fitting. Because really the minute that they start sleeping well, it's night and day for people. They don't feel sleepy anymore during the day. So it's one of those things in medicine that's so cool to see for me, that when somebody's appropriately wearing their CPAP machine, how differently they feel during the day.
Very cool.
Yeah. Okay. So let's talk about our last category, the sleep-related movement disorders. So these are simple stereotype movements that can disturb sleep. This is things like restless leg syndrome, so this complaint of strong, really nearly irresistible urges to move the legs during the evening or night, and you can get relief from walking or moving. Something called periodic limb movement disorder, which is these highly stereotyped limb movements that are associated with sleep disturbance during sleep. Sleep-related leg cramps, and then sleep-related bruxism or gritting of teeth. My husband has this. He actually, a lot of people have this, and it can relate to, them wearing down on their teeth and having to wear like a guard. And it happens more often when somebody's sleep deprived or stressed. But that's pretty common, sleep-related bruxism. So take a look at your mouth, your teeth. To ask your dentist about it too, because they can tell you if you got this issue. That's the movement issues. And then I think Ben last week, I don't know if Ben's on today, but he asked a question about what the brain looks like during general anesthesia or coma, and then what it looks like in death, okay? Actually, I don't think he asked about the death. I think I added that. So some of this we reviewed. So this is awake with eyes open, and then this is awake with eyes closed, the difference between alpha and beta type of pattern. B over here is under general anesthesia. Okay, so you get this paradoxical excitation in the minimally conscious state. Here, the vegetative state or coma, it looks a little bit different. And then a coma itself, there's something called burst suppression. So that's this pattern here. This is what the brain looks like in brain death. So kind of this isoelectric same pattern, okay? And compare that to what it looks like during normal sleep. So obviously you need to get a lot of information. You'd want to know if somebody was in a coma or not, but that's the differences between the two.